Good afternoon and good morning. This afternoon and this morning, we're going to be discussing the implementation of MIPS in your practice. That's the merit-based incentive payment system and the webinar that the Academy has organized around this topic. It is clearly an important change in the way we've done business in Medicare Part B and will be affecting much of how we practice for the next 5 to 10 years. Our speakers this afternoon will be Ms. Rebecca Hancock, who's Director of the IRIS Registry for the Academy, Sue Vishrilli, who's Director of Coding and Reimbursement for the Academy and the American Association of Ophthalmic Executives, and listening in and helping us where we forget things, Dr. Flora Lum, who is Vice President of the Academy for Quality and Data Science. It's very important to recognize that the information in this presentation reflects what we know as of today, and it's based upon the final rulemaking for the MIPS program, which was just released a little over 2 weeks ago. This information will be constantly updated by the Academy at the website that you can see there, aao.org/Medicare. The content is copyright by the American Academy of Ophthalmology and may not be reproduced or transmitted in any form without the express written consent from the Academy. Why do we care about MIPS? The MACRA bill, which replaced the SGR a little over a year ago, is very important in how physicians get paid in Part B. Now, in the recently completed presidential election campaign, there was much said about the Accountable Care Act. It's very important for ophthalmologists to recognize that a replacement, a repeal, a tweaking of ACA does not affect the MACRA payment system. However, there could be tweaks to this system, and certainly there are a lot of changes we would like to suggest to our leaders in Congress and at CMS, because as I think you'll decide as this goes on, that this program is complicated. So we have polling question 1. It's regarding 2015 reporting, and I believe you're to answer whether you reported successfully. There we go. The early achievers are already putting their answers up there. We'll wait just a few more seconds. So we have about a quarter of the electorate in. So as we can see, in 2015 reporting, the EHR IRIS Registry combo represents about half of the participants on this call in terms of success. An additional quarter either reported what the IRIS Registry without an EHR or via claims. So about 3/4 of the listeners today were successful for 2015 reporting. That's really quite remarkably good. And so there we have those results. And let's move on to, for 2015 reporting, the last day to appeal those results is November 30, 2016. So just a little over a week from now to get that completed if there's a problem with your reporting notification. Now, turning to 2016. And these will be what you expect is happening this year for you. And the early returns show that the EHR IRIS Registry pathway appears to be the overwhelming method of succeeding in this program. great. I think we can go on. I think the poll demonstrates what it is. People were successful in 2015 using the EHR IRIS Registry combo, although there were nice minorities who came in other routes. But for 2016, it looks like the adoption has increased for the IRIS EHR pair combo. So we're going to talk today about the replacement programs for the Meaningful Use and the PQRS programs that have happened in the past. And this is known as the Quality Payment Program, which is the new name for MACRA. The final CMS rules for the reporting year of 2017 were just released, as I mentioned earlier, and it's important to begin to prepare now to meet those requirements. However, the final rule did give much more breathing space than was there before because of some delays and some easing of the transition from the old fee schedule system to the new MIPS system. For those that haven't been aware, our performance in 2017, so we have to do all of the tasks in 2017, and that's going to affect payment on our Medicare Part B reimbursement in 2019. So it'll be a multiplier that will be applied to your allowed charges that year. All right, what are the payment adjustments? The purpose of the MIPS program was to move doctors out of traditional fee-for-service and move them into other payment for value kinds of systems, which, of course, economists have talked about a lot, healthcare policymakers talk about a lot, but the reality was they could not figure a way to move everybody into that kind of payment system right away, but rather had to continue fee-for-service with modifications, and in a way that continues to be what the MIPS program is. There are some very important parts about the MIPS program. In the first row, remember that part of the macro legislation gave us 5 years of positive updates at about 0.5% on the physician fee schedule. Now, in 2016, it actually went down because of budget neutrality a little bit. In 2017, it appears it's going to go up just a little bit, not quite at the 0.5, but at least it's positive. But in the years affected by the MIPS program, there will be doctors who can go up as much as 4% in 2019 or down as much as 4%. And then that penalty or that bonus increases annually until it reaches 9% plus or 9% down. It's important to realize that this is a budget neutral program. So by law, there have to be winners and have to be losers. And the amount of money moving from doctors on the low side to doctors on the high side has to balance. For physicians who can end up in alternative payment models, which is the other half of the quality payment program, a part which we do not think that most ophthalmologists will be in, they will get 5% if they're successful. The basic reason why most ophthalmologists won't be in those programs is it's hard to get enough of a percentage of your allowed charges into an APM to qualify for the bonus. The levels are very high. In the MIPS program, in the bottom row, it says additional funding. And this is the incentive. So we have the little green arrows up and red arrows down. But here we've taken $500 million each year and said that if you're really a terrific person, you're the A-plus student, or in this case, the A-plus doctorate, at least in terms of this payment, you can get up to a 10% kicker on your money. It really will go for those people that probably are in the top 12% of doctors, the top 25% of the winners. So the merit-based incentive program is the main option for ophthalmology. The impacts on payment begin for us in January 19, but we're graded in 2017. It consolidates and replaces existing incentive programs. So they get new names, they get reworked a bit, but they still do exist. So PQRS is now sort of the quality. Meaningful Use gets a new name, which we'll see in a little bit later, the Advancing Care Information category, and the value-based modifier sort of overlies this whole program but goes away with this name and comes back. And the incentives that we can get, or the penalties, are based upon how we do in 4 measurement categories. We originally thought that this program was going to have to roll out, and to be really successful, you'd have to be ready on January 1st. And those physicians that can be ready on January 1st are in a great position to do very well in year 1. But those who aren't can still succeed and certainly not get penalized to a great extent. So they said, we're going to have a pick-your-pace transition plan. By the way, their wording, not ours. It increases the flexibility for 2017 MIPS reporting from the proposed rule. And basically, if you are breathing and can fill out a form or two, you can avoid penalties in 2019. It made it that much easier, and that was a response to the really consistent lobbying that this was too big a change to expect doctors and doctors' offices to turn on December 31st and have, switched their entire way of doing business. So we're left with 4 MIPS options for physicians during the 2017 year, and these will change, and we expect the 2018 rule to actually modify again what was in the proposed rule. So we do have the do nothing, and you could certainly do that. And if you have little money in Medicare or you won't be working in 2019 or beyond, it doesn't matter. But if you do nothing, you receive a 4% penalty on your allowed charges. You could submit some data under MIPS and completely avoid the penalties in 2019. It will be very easy. Partially participate, there are some smaller bonuses, not to the 4%, but at lesser levels of a fraction of a percent to 1 or 2%. And if you really go full bore, fully participate in MIPS, then you could be eligible, depending upon your overall score, to earn larger bonuses and perhaps be in play for the bonus money that we talked about before, the $500 million that gets spent annually on the super-duper docs. So the Pick Your Pace program shown here basically says the same thing. If you don't participate, you go down. If you test, which basically says you submit one quality measure or one improvement activity, you can have you basically have zero, no upside, but no downside. A little bit of participation, the blue gets bigger and you'll do better and probably get either no bonus or a little bonus. And full participation, you should be able to get up towards the 3, 4, or even beyond in terms of percent. The reason it's unclear in the partial participation what bonuses you'll get is that CMS doesn't expect many doctors to be in the red because it's really easy to not be in the red. So pick your pace on payments. Let's see, we've got that. MIPS is budget neutral, as I mentioned. Penalties make up the pool. If few eligible clinicians receive a penalty, the bonuses will be commensurately lower, and there may not be enough money to spread around. And that exceptional performance category, as we'll see, if you happen to get a grade of 70 on a scale of 0 to 100, you can qualify for additional bonus money, which can be 0.5% up to 10%, and that's determined by how many people are in that category, and so how much money they have to spend for doctors. And actually, if you took $500 million you can see there could be a lot of money if you've only got 12% of providers in that category. So who's excluded from MIPS? Who can hang up right now if they want to? So you're automatically excluded if you see 100 or fewer Medicare patients in a year, or you have less than $30,000 in allowed charges. Remember, optometrists do count as physicians and are using the same measures. But one category of provider, a pediatric ophthalmologist, for instance, could easily be excluded depending upon whether or not they see any senior citizen strabismus. If you're newly enrolled in that first year, you don't participate in this MIPS program, and you have a neutral modifier. And if you happen to participate in an advanced APM and meet the required thresholds, you are excluded from MIPS. Again, few ophthalmologists will be in that category. The bottom line, which says CMS is estimating, based upon their review of charges, 27% of ophthalmologists will be excluded from MIPS in 2017 for one or more of these reasons. So there'll be new physicians, there'll be low-volume physicians, subspecialists in particular areas that would not be included. So clearly not everybody is involved, but most of us are involved to some extent. So there are 4 categories for our grades, and this really is that. This is like having 4 grades in elementary school. The only thing different about these grades is they're not all equal. So math might be 60%. In this case, it's quality measures. But something like penmanship, which I used to be good at but no longer, is much less valuable at 25% for advancing care information or using EHR. And clinical practice improvement activities, almost like civics, is 15%. And resource use will be 0% in 2017. So these are the 4 areas we're graded. Quality measures are the most important and represent 60% of our score. And that's going to be an important part of what we talk about, because to succeed then in this program, you have to do well in this category, at least in the early years. In future years, quality will go down a bit, and other categories will come up a bit, particularly resource use over time. Now, I think we're going to go to the next slide, and then I'm going to ask the next speaker, who's going to pick up at this point.
Thank you, Dr. Repka. So this is Rebecca Hancock now speaking. So as Dr. Repka just reviewed, the MIPS scores are on a scale of 0 to 100. And because of the flexibility provided by CMS and Pick Your Pace, as long as you get a score of 3 out of 100, you will avoid negative payment adjustments in 2019. And this can be achieved by submitting 1 quality measure or 1 practice improvement activity at any point during the year next year. MIPS scores that are between 3 and 70 may be eligible for a small incentive payment that would be capped at 4%, but could be lower to maintain budget neutrality. And scores that are 70 or higher could be eligible for the additional incentive payment of at least 0.5% from the additional funding authorized in the law. So now I'm going to jump into the specifics of how you can participate in MIPS next year. So as we explained, there's significant flexibility offered through the Pick Your Pace initiative. And to avoid penalties in 2019, you only need to get a total score of 3. Again, this can be accomplished by reporting on as little as 1 quality measure 1 time for 1 patient during 2017. Like PQRS, this could be reported through the IRIS Registry, your EHR, or by claims reporting. All Academy members should be able to accomplish this and avoid penalties in 2019. If you want to be eligible to earn a bonus under MIPS, you must earn a score higher than 3. To do that, you will need to report on more than 1 quality measure. For each quality measure reported, physicians will be awarded at least 3 points just for successfully submitting data. Even if you report on, if you report on several quality measures in 2017, even if it is for a period of less than 90 days, you could potentially earn enough points to qualify for a small bonus in 2019. So while you have those options to report less and avoid penalties, the Academy encourages its members, especially those that have experience reporting PQRS and those that are on IRIS Registry and those with an EHR, to fully participate in MIPS next year in an effort to not only maximize your scores and potential for incentive payments, but also to use 2017 as a practice year to understand how you are doing under MIPS and to learn what you will need to do in future years when the pick your pace flexibility is not an option. So to maximize your quality score, you must report on 6 quality measures for a period of no less than 90 days on 50% of your applicable patients. Physicians reporting by claims would only report on Medicare patients, which includes Railroad and Medicare as secondary payer. However, physicians using IRIS Registry or an EHR must report on 50% of patients from all payers. You must report on at least 1 outcome measure, or if you do not have an outcome measure, then 1 high priority measure. You can earn bonus points for additional outcome measures reported and for electronically reporting quality measures, such as through your EHR or through the IRIS Registry EHR integration. Each quality measure reported is worth up to 10 possible points, and points will be awarded based on your performance score. As I previously mentioned, as long as you successfully report on a measure, even if you do not report on 50% of your patients or you do not report for 90 days, you will earn 3 points for that measure. Large groups with 16 or more eligible clinicians will be measured on the 6 measures they report, but in addition, they're going to be measured on a measure called the All Claims Readmissions measure, which CMS calculates using their administrative claims data. This is one of the measures that is being carried over from the value-based modifier program. No reporting is required for this measure. It's calculated entirely based on claims that CMS has received. The important thing to note is that in order to be evaluated on this measure, physicians must have at least 200 patients that qualify for the measure. And because of our specialty, it is highly unlikely that ophthalmologists will be evaluated for this measure. So most ophthalmologists will be excluded from this measure. The majority of ophthalmologists will be evaluated for quality based on the quality measures that they report for MIPS and their performance rate on those measures. So you might be asking, how does CMS determine how many points I will be awarded for each measure? So they will compare your performance rates to benchmarks from the 2015 reporting year. They essentially take the performance rates for all providers that reported on a measure in 2015, and they break those into deciles. Your 2017 performance rate will be compared against those deciles, and you will earn points according to which decile your performance rate falls. So if you perform perfectly on a measure, meaning let's say you get a performance score of 100% on a measure and you perform perfectly, then you can earn the full 10 points. I just want to note that performance rates are different than reporting rates. CMS will also award you bonus points. You will get 2 bonus points for each additional outcome measure that you report beyond the 1 required outcome measure. You will also get bonus points for reporting measures electronically. You will get 1 bonus point for each measure that is reported using an EHR or through the IRIS Registry EHR integration option. So now I will turn it over to Sue.
Thank you, Rebecca. What quality measures does IRIS Registry offer? For physicians with EHR, there are 16 possible electronic quality measures offered through IRIS Registry. Of the 6 you select, at least one must be an outcome or a high priority measure. Note that IRIS Registry offers 4 outcome and 5 high priority options from which to choose. For physicians without EHR, IRIS Registry plans to offer 48 measures from which you may choose 1 to avoid the penalty or 6 to go for the bonus. Of the 6 you select, at least 1 must be an outcome or high priority measure. Note, IRIS Registry offers 28 outcome and 10 high priority measures from which to choose. This slide identifies the number of outcome and high priority measures by specialty. For EHR, a comprehensive cataract surgeon has 2 outcome options. As an upcoming slide will detail, the outcome options are Measure 191, 20/40 or better visual acuity within 90 days following cataract surgery, and Measure 192, complications within 30 days following cataract surgery requiring additional surgery. A high priority measure for a retina specialist or comprehensive ophthalmologist is Measure 19, communication with the physician managing ongoing diabetes care. For practices who will manually enter data into IRIS Registry or report via claims, there are many options for outcome or high priority by specialty training. As of today, CMS just posted the draft measure specifications. However, we do not anticipate as we look through them significant changes, with the exception of the addition of the new ICD-10 codes that impact diabetes, macular degeneration, and primary open-angle glaucoma. IRIS Registry, however, is planning a few changes. As the cataracts measures group will no longer be an option for reporting under MIPS, IRIS Registry is moving away from the 2 burdensome measures that would require post-surgery surveys of at least 50% of all your qualifying cataract cases. Measure 318, falls screening for future risk, is moved from manual reporting to EHR only. Adding Measure 1, diabetes A1C poor control, to EHR reporting, and for neuro-ophthalmology, adding Measure 419, overuse of neuroimaging for patients with headache and normal exams. For the first year of MIPS, physicians are not required to report on measures across a set of quality domains. However, as previously stated, you must report on at least 1 outcome or high priority measure. If you are reporting via IRIS Registry with your EHR, here's a list of those 16 measures, of which 9 are identified as outcome or high priority measures. Select your 6 from this list, with 1 of the 6 being identified as an outcome or high priority measure. If you submit via claims or manually enter your data into IRIS Registry, this and the subsequent slide are for you. To avoid the penalty, select at least 1 measure and report it several times to assure CMS has received the information. But if you choose to maximize your potential and go for the gold, select 6. Note, however, that unlike PQRS, you will get partial credit if you fail to report on 6 measures successfully and may have the chance of earning a bonus. Again, remember, 1 of the 6 must be an outcome or high priority measure. If I were a retina specialist without EHR and I hope to qualify for a bonus, I might select the following 6 measures. On this page, I could identify diabetes A1C poor control, which is also an outcome measure, macular degeneration, a dilated exam, diabetic retinopathy, communication with the physician managing ongoing care, note that's a high priority, diabetes, a dilated eye exam, macular degeneration, the ARIS study, and on the top of the next slide, tobacco use screening. If I'm reporting from claims, I'll report all 6 measures on at least 50% of my qualifying patients. But as a precaution, or to ensure success, I'm going to report on all my Medicare Part B, Medicare as a secondary payer, and Railroad Medicare patients for a minimum of 90 days. Let me say that again. From claims, I'm going to report all 6 measures on all of my Medicare Part B, Medicare as a secondary payer, and Railroad Medicare patients for a minimum of 90 days, hoping to achieve at least 50% success. For those of you doing manual data into IRIS Registry, I would report those 6 measures on all of my patients. That includes all payers for 90 days. Or I might choose to report both options, claims and manual data entry through IRIS Registry, just to make sure I'm successful as possible. As our Academy President, Dr. Rich, says, this is the belt and suspender method of reporting. If you report using 2 different mechanisms, such as claims and manual data entry, CMS will take whichever one is most successful and results in the highest MIPS score. Like the retina example I gave, examples of which measures each specialty may choose are under development and will be posted to the Academy's website soon. If the reporting option you choose is to enter your data manually into IRIS Registry, measures on this slide and the following slide are even more potential measure options. These measures were developed by the Academy in conjunction with the specialty societies and are pending CMS approval. We expect to receive notification of CMS approval in April or May of next year. Remember, unlike claims, manual data entry into IRIS Registry does not have to be done in real time. Therefore, it's okay to wait for approval of these additional measures before reporting begins. What are the due dates by which the measures must be reported? For those who submit via claims, all your 2017 data must be processed by CMS by March 1st, 2018. If manual data entry is the best option for those of you without EHR, sign up now for IRIS Registry if you haven't already. Manual data entry must be completed by January 15th of 2018, so IRIS Registry can submit on your behalf by March 31st. And for those of you who report via EHR, all data must be uploaded by March 31st, 2018, so that IRIS Registry or your EHR vendor can submit on your behalf. Rebecca, back to you.
Thanks, Sue. So now I'm going to move to the second MIPS category, which is Advancing Care Information, which is the new name for the Meaningful Use program. The ACI requirements are based off of the Meaningful Use Stage 2 and Stage 3 measures, but CMS has made some key changes. Eligible clinicians are only required to report on 4 measures during the transition year to get credit under ACI. These only have to be reported on 1 patient, so you no longer are required to meet those patient thresholds of 30, 40, 10%. But the more you report, the higher your score will be. Additionally, practices will have the option to report ACI at the group practice level. Another good thing is that the problematic patient portal measures are now optional. In addition, the computerized provider order entry measure was removed, so this eliminates the need to have your office staff certified as scribes. Advancing care information can be reported through attestation on the CMS website like is currently done for Meaningful Use. CMS will also allow you to report ACI using a registry such as IRIS Registry or directly through your EHR. So this slide is about the EHR technology requirements. So CMS is mandating that all eligible clinicians use EHRs which are certified to the 2015 edition and 2018. However, that upgrade is optional in 2017. Most physicians are going to be on 2014 technology next year because the EHR vendors are still working to program the upgrades to their systems. This is important to know which edition you are on because practices that move to the 2015 edition software have the option to report on different measures under advancing care information, but they can also choose to report on the transition measures, which is what I would recommend. So under advancing care information, the hardship exceptions will continue to exist just as they do today under meaningful use. If you qualify and successfully apply for a hardship exception, your ACI category would be reweighted to 0, and those points would be shifted to your quality score. Some of you may be participating in your state's Medicaid Meaningful Use program. Medicaid Meaningful Use is completely separate and unrelated to MIPS and advancing care information. You can continue to participate in your state's Medicaid Meaningful Use program if you are still eligible to earn bonus dollars from that program. But if you are no longer able to earn those bonuses or you no longer are interested in participating in your Medicaid Meaningful Use program, you can discontinue your participation beginning in 2017 and instead focus on MIPS. So the ACI category essentially has 3 components: a base score, a performance score, and a bonus score. Combined, these 3 components add up to 155 percentage points. However, the highest score that you can earn under ACI is 100. So if you get 125 percentage points or 135, that would translate to an ACI score of 100, and then you would get all 25 ACI points towards your total MIPS score. Note that the base score, which is 50 percentage points, is absolutely required. The base score is earned by reporting each of the required measures on at least 1 patient. If you fail to report on any of the required measures, you will get a 0 for the entire ACI category, regardless of whether or not you perform well on some of the other measures. So this slide shows you the ACI transition year objectives and measures, and the transition year is 2017. The measures that are in bold are the ones that are required for the base score and required to get any credit under ACI. Those are the ones that you must report on for at least 1 patient in order to get any points for ACI. The other measures on the screen are optional. You can focus on the ones that work well for your practice and that you can earn high points on to maximize your score. Note that participating in a specialized registry such as IRIS Registry will earn you 5 bonus points. So these are the measures that are required for the base score in the transition year. These must be reported on at least 1 patient in order to get the 50% ACI base score. These measures are the security risk analysis measure, electronic prescribing, patient electronic access, and the health information exchange measures, which all come from Meaningful Use Stage 2. So if you've been doing Meaningful Use, these should look familiar to you. The measures listed on your screen now are the measures which can be reported to earn points towards your ACI performance score in the transition year. Points are awarded based on your reporting rate for each measure. For example, the patient-specific education measure. If you meet the measure for, let's say, 50 out of 100 patients that you see during your 90-day reporting period, you will earn 5 percentage points towards your performance score. Finally, you can earn bonus points under ACI for participating in a specialized registry such as IRIS Registry. Bonus points can also be awarded for completing a clinical practice improvement activity using your EHR. Clinical practice improvement activities will be explained next, but I did provide an example on the screen. One clinical practice improvement activity is for your practice to provide 24/7 access to a clinician for urgent care or emergent care advice. You can earn a 10% bonus score under ACI if you do that activity using your EHR. So for example, using your EHR's secure messaging function to send or respond to patient messages outside of business hours. So now I'm going to move on to the next category, which is new, and this is called the clinical practice improvement category. If you want to only avoid penalties next year, as we mentioned earlier, you can report on just one quality measure, but you also have the option to report on one clinical practice improvement activity, or CPIA. If you want to earn a small bonus, you would need to report on more than one CPIA. If you are participating fully in MIPS and seeking to maximize your score under MIPS, you would need to complete a sufficient number of CPIAs for a 90-day period in order to reach 40 points. So you're probably asking, how do I get to 40 points? The activities which have been defined by CMS are weighted. They're either high or medium. The high activities are worth 20 points. The medium activities are worth 10 points. So to get to 40, you could report on 2 high-level activities, or 4 medium activities, or a combination of both. However, small practices are the exception. For them, the point values are doubled. So practices with 15 or fewer eligible clinicians only need to report on 1 high-level activity or 2 medium-level activities, and they can get full credit under the clinical practice improvement category. In order to report your clinical practice improvement activities to CMS, you must attest that you have completed that activity. Attestations can be submitted directly to CMS on a new CMS attestation website that they are creating, which may be similar to the Meaningful Use attestation website, except that you would only be required to attest yes or no that you have completed an activity. If you use IRIS Registry, you have the option to have IRIS report your attestations for you. Or you can have your EHR vendor do that if your EHR company offers CPIA reporting next year. So there are about 90 clinical practice improvement activities that CMS has defined. While some of those have no relation to eye care or the workflows of ophthalmology practices, many of them are actually relatively easy to achieve. So we've included a few examples on the screen. Note that at the bottom of the high-level activity and also in the medium activities, there are several activities in which registry participation counts. So if you are participating in IRIS Registry and meeting the registry-related activities on the screen, you will automatically get credit toward the CPIA category. So now I'm going to turn it over to Dr. Repka to discuss resource use.
Thank you, Rebecca. So resource use was going to be the controversial topic for 2017, but it's been postponed. And so it's the easiest to understand for 2017 because we will get scores from CMS, but it's weighted at 0%, so it will have no impact in 2019 payments. It's expected to have impacts beginning in 2020 payments. So resource use is controversial because many of us don't think CMS can do it very well and can't really risk adjust very well. This is a very passive score. You do nothing. CMS calculates how much you cost them using administrative claims, and they have a number of measures which are at the bottom of the bullet. You can see physicians measured, and feedback will be provided on total per capita cost, Medicare spending per beneficiary, and so that would be in your practice, and there will be some episode-based measures. And if you have 20 or more patients, they can be used to compare to others who have 20 or more patients. The first ones will be cataract surgery episodes. We do expect some that will also be in retina. But this is a category we're going to learn a lot about. Every 6 months, CMS is supposed to send you a score. For those of you that were in regions that got QRUR reports, or Quality Resource Use reporting, you've seen what their reports can look like. Some might even say they're intelligible. But we will be seeing those, and we'll probably be better able to explain what happens in the future with those and how they may impact. This area would have been 10%, and again is 0% for next year. Now, we've paid somewhat short shrift to the alternative payment models, but there's a little bit of impact in the MIPS program. And it starts with not all APMs are advanced APMs. To be in the APM part of the quality payment program, you have to be in an advanced APM, which is an organization that must bear significant financial risk, and that's laid out in the law and in the regulations of how much money you could lose. But they must also make payments to their providers based upon quality measures that are very similar to the quality measures in the MIPS program, and participants must use a certified EHR. So it's just a different program using many of the same rules, and you just get graded a little bit differently. In our view, significant advanced APM barriers exist. The threshold in number of patients that must be participating is too high. Of your revenue, 25% has to be in that program, or 20% of your patient visits has to be in that program. And they're just, given what's out there in the world right now, there's very little that suggests that ophthalmologists could succeed in those kind of programs. But accountable care organizations that don't qualify to be in advanced APMs are subject to MIPS, so that if you are a participant in an ACO, you are going to be graded in a system that is exceedingly similar to the MIPS program. And these are most of the Medicare ACOs. For instance, it includes all of the Track 1 ACOs that are out there now. And the keys here are all participating TINs in a MIPS ACO receive the same score. So it's very collegial. The category weightings are slightly different. You can see a little less in quality and a little bit more in CPIA measures. And again, as Rebecca said, everybody on this call should be able to complete a CPIA attestation if the site was available by April 1st, but it won't probably be available, but after the first 90 days of the year. The MIPS scoring is covered on this image. These are the shared savings ACOs. Again, these are those that don't qualify as advanced, and it just has the intricacies of how individuals are going to be graded. Again, even in this category, the expectation is there will be few ophthalmologists who are participating, but there is a path. For somebody who's in the right place that happens to be in one, there may be a way to succeed. Now, if you are in such a circumstance and the ACO is participating in the MIPS program, but you can also participate in IRIS Registry, under MIPS, you can report quality measures using the IRIS Registry. And the advantage, and that hasn't been true in the past, incidentally, But in this new program, you can report as part of the ACO, but you can also report your quality measures through IRIS, and so that if the ACO fails, and we know they do from time to time, this will protect you from automatic downward adjustments. So just an option, and certainly easy for those that are linked with IRIS. So what do you need to do in 2017 to get ready for 2018? If you're in a MIPS ACO, report at least one measure to avoid the penalty, and the IRIS Registry can be used as a backup if you're in an ACO. I should say everybody should report at least one measure to avoid the penalty, either in ACI or in CPIA, the Clinical Practice Improvement Activities. Use 2017 to prepare for 2018. I think that's really our revised take-home message since the time this webinar was forecast. If your EHR needs to be upgraded, consider doing that, because you will need to have 2015 software for in the 2018 reporting year. And if at all possible, and it's sort of like speaking to the converted who are on this call, participate in the IRIS Registry. As we saw at the beginning, more than 70% of people were integrated EHR IRIS Registry. So I think that IRIS has a job, Rebecca and Flora, to get everybody linked, or everybody that can. And then begin to look at performance rates. And in general, group reporting looks like a simpler option for many. So now we're going to open for questions and answers, and the best MC of all for that would be Sue Vishrilli.
Thank you, Dr. Repka. The following questions were submitted to MIPS@aao.org prior to today's course. Answers to any questions that are received via this communication email or emailed to MIPS@aao.org following the webinar will be added to the website content. So everyone will receive an answer to their question. Let's begin with our first question. I have an EHR and participate in the IRIS Registry. What should I do next year?
So I'm going to start the answers, and fortunately the answers are here for everybody, but you're a winner. If you should do well under MIPS. You've sort of practiced under the previous programs. I think it's just important to make sure that everything is set up to submit data in each of the categories to maximize the total points, aiming for that super score of 70 or higher. And that's where you'll get the maximum revenue neutral bonus, which could be up to 4%. But then you're in play for the 0.5 to 10% exceptional performance bonus, which would be fantastic for ophthalmologists.
I don't have an EHR, and I haven't had success under MIPS, under PQRS. What should I do next year?
So I'll take this one. So if you do not have an EHR and you've never participated in PQRS before, or you've never successfully participated in PQRS before, but perhaps you're tired of receiving the penalties, you might want to take advantage of the flexibility that CMS is providing next year and report on one quality measure for a very small number of patients, but no less than one patient. Or you could report on one improvement activity. If your submission is successful, then you would completely avoid penalties. And also, if you've been doing claims reporting and you've never used IRIS before, you could use 2017 as a practice year, and you could continue to report by claims, but you could also try out IRIS Registry next year and manually enter data in their web portal, or perhaps consider obtaining an EHR and integrating it with the registry. Because again, CMS will take whichever score is the best if you report by two mechanisms. So it's a great year to practice.
the number one question asked is, without an EHR, is it possible to obtain any type of bonus?
So it is really hard, I think, is the bottom line. These programs all, since Meaningful Use's introduction to this program, are intended to move doctors to EHR platforms. That said, if you can get well enough on some manual reporting of quality data and do those essentially two activities in clinical practice improvement activity categories, you certainly will avoid the penalty. I think it's a bit of a stretch to get a score high enough in the initial year to get a bonus, but who knows? It's certainly better than nothing if you can.
Advancing care information is replacing meaningful use. Are there any physician-level programs other than MIPS that could result in payment adjustments after 2019?
So no, not at this time. MIPS is replacing meaningful use, PQRS, value-based modifier. So beginning in 2019, all of those penalties will no longer exist, and we will only have MIPS. That's as much as we know at this time.
I guess I would add, Sue, that with tinkering by the new administration and the new Congress, one never knows.
Right.
Should those of us without EHR apply for a hardship exemption again?
I think that got to apply. It may help. So hardship exemptions will be available for not being able to participate fully in the ACI, but we don't know the process yet, and we'll certainly announce that to the membership as soon as it's available.
The cataracts measures group and diabetic retinopathy measures group, are they still an option for reporting MIPS?
No. So CMS has eliminated all PQRS measures groups under MIPS. So the cataracts measures group and the diabetic retinopathy measures group are no longer an option. The individual measures within those groups will continue. And the good news under MIPS, unlike PQRS, is that you can get partial credit. So if reporting on 6 measures for 50% of your patients for a 90-day period is too much, you could do 4 measures, and you could still get significant credit towards your quality score.
I thought we had to report at least 90 days in order to qualify for a small bonus.
Do you want me to take this, Dr. Repka?
Sure. Go, Rebecca.
Okay. It is possible to earn a small bonus even if you do not report for 90 days. So as long as you have a score higher than a 3, then you could be eligible for a small incentive payment. And so, for example, every quality measure that you report, even if it's not for a 90-day period, you would get 3 points as long as the data was received successfully. So you could get a score higher than a 3 by reporting on multiple quality measures for a period of less than 90 days. But keep in mind that your score would still be pretty low, and because of budget neutrality and the fact that not very many physicians would be getting penalized next year because of pick your pace, the bonus amount that you would qualify for would likely be very small.
Yeah, I think the estimated penalties, incidentally, for those on the call is about $190 million. So it's not huge amounts of money swinging from one side to the other simply because this passing score is so low.
Many have asked, do we have to decide how we are going to report and let CMS know at the beginning of the year?
So fortunately, the answer is right here. No, just report when you're ready. And that's part of the reason for the timing of this call and to spend December figuring out what you can do in January.
Should we report at the individual clinician or group practice level?
So every practice is different, but we think there are some benefits to reporting MIPS at the group practice level if you have multiple eligible clinicians in your practice. So in the past, CMS has required practices to register for GPRO if they want to report at the group level, but fortunately they're removing that registration process because it's been very confusing and has resulted in many accidental wrong registrations. So we would recommend for many practices reporting at the group level because you have a wider option of measures to choose from. And if one physician, completes a clinical practice improvement activity, the entire practice could get credit. So there's many benefits to reporting at the group level. But please note, if you report at the group level, you must do so for all categories of MIPS. You cannot report at the group level for quality, but at the individual level for advancing care information. You have to be consistent across all categories.
Yeah, and everybody will get the same score, I guess, is the important thing out of that.
Right.
To report quality measures via claims, must I only report on 50% of our qualifying Medicare patients? And as a second part to that question, what if we are transitioning from paper to EHR?
So a different question is showing on the screen. Okay.
What?
There you go. Okay. So again, you only have to report on one patient to successfully avoid the penalty. That's all you have to do. If you want to maximize your score and try to qualify for a bonus, then you should report on 6 quality measures. If you're reporting by claims, you would report on 50% of your Medicare patients. If you're reporting by EHR or registry, then you would report on 50% of your applicable patients across all payers.
In a group practice, if more than half don't participate or successfully participate, is everyone in the practice subject to a penalty?
No.
No.
That was the case, but not true in MIPS.
Right.
I belong to an accountable care organization. If my ACO fails to report MIPS for me, may I report from myself from my practice as a safety net?
Yes. So as Dr. Repka covered, if you are in an ACO and you want to just, report on your own as a safety net in case the ACO for some reason fails to meet its reporting obligations, you may do that, and you may do that with IRIS Registry.
Will it be harder for practices to receive a bonus in 2019 because CMS is making it easy to participate in MIPS in 2017? Will enough clinics get a penalty to balance the program?
So, yes, they have to by law, and the amount of money in the bonus in 2019 probably will be fairly small to nearly invisible for many of the practices who get over a score of 3. As we mentioned, there will be some money moving from those that decide to not participate. Estimates are pretty low, 190 million or so. But there is the possibility for the good performers, for the excellent performers to get a chance at the extra $500 million or $500 million that's there. That's not subject to budget neutrality, although it is capped. You can't get more than 10% of a bonus. And if you're in that category, you have to get a minimum of 0.5. So it could be a little money, or it could be a modest additional amount of money on the program.
If our practice is already at 100% performance on some quality measures and the benchmarks are high, can we still earn a bonus?
Yes, of course you can earn a bonus as long as your score is above 3 and certainly if it's above 70. But to address this issue, under the value-based modifier, because of the way that they tiered practices and decided if you were high quality or low quality, for some measures, when the benchmarks were very high, it was impossible to be considered high quality, even if you had a perfect score of 100%. But for the first year of MIPS, CMS is allowing physicians to earn maximum credit for a measure if they get a perfect score, regardless of the benchmark.
A very popular question. Is there a group reporting option for MIPS?
Yeah, so as we said, yes, there is, and the practice does decide to do that. It does it for all the 4 categories in the program, and everybody ends up with the same score, the same grade, and would get the same adjustment in their fees.
And I'll just add, I know there's a lot of questions coming in asking if IRIS Registry allows reporting by the group, and the answer is absolutely yes. We've allowed group reporting for PQRS for the past 2 years, and we'll do the same under MIPS.
If we report via the IRIS Registry, will we meet all the requirements for quality and advancing care information?
So you can meet all of the quality reporting requirements using the IRIS Registry, but the advancing care information still requires you to use your EHR in a specific way in order to get points. So you must do e-prescribing. You must have a security risk analysis in place. So there's still certain things that you must do to get credit under the advancing care information category with your EHR in your practice. However, new under MIPS, instead of attesting on the CMS website each year like you do for meaningful use, you can just share that data with IRIS Registry as well as your clinical practice improvement activity, and IRIS can report all of your MIPS information to CMS so that you can get scored under MIPS.
Many are asking, we're not currently signed up using the IRIS Registry. How soon can we sign up?
So practices can sign up at any time. It's a rolling process, and anybody that's already participating in IRIS Registry, and we saw many of you on the call are participating, that there's no need to re-register. This continuation is fairly automatic.
And what are the IRIS Registry deadlines for MIPS?
So if you have not registered for IRIS and you'd like to participate next year, if you have an EHR, then you would need to register by June 1st, 2017, so that the registry could integrate with your EHR in time. If you do not have an EHR and you are going to be using the web portal to enter data, then you would need to register by October 31st next year. And then you would need to have all of your data submitted to the registry by January 15th of 2018. And for all IRIS Registry participants, you would need to have your data release consent form signed and returned by January 15th of 2018.
Rebecca, could I ask a question? If somebody
Sure.
decided to do the web portal through IRIS and it was a solo practice, what kind of workload do you think that would be in those 2.5 months, November, December, and first half of January, to complete the end?
Well, under MIPS, it's unique because you only have to report on a very small number of patients, even as little as 1, if you want to avoid the penalty. So just reporting one measure on one patient would not be much work at all. If you wanted to go for the bonus and report for a 90-day period on 50% of your patients, then it would take some time, but it could be worth it. It would be good practice because while next year the bonus amounts are going to be small, in future years they could be larger. So I would definitely recommend that practices try it out and see how it goes for them, because in future years more is going to be on the line and they would not have the option to report on one measure, for example.
Oh, this skipped ahead just a moment. Let me go back. there are still a couple of questions that aren't showing up on the screen. I see patients in multiple practices. How do I report MIPS?
So I can do that. You actually have to be scored in each practice you participate in individually. So you've got to actually do it for each set, and then actually CMS ends up weighting your score depending upon your volumes at each to determine your potential bonus in 2019.
And our last question, can I avoid MIPS payment adjustments by going non-par with Medicare?
The answer is no. If you go non-par with Medicare, you would still be subject to payment reductions if you don't successfully comply with MIPS. I know there were some practices that thought they could avoid the penalties under PQRS and meaningful use by going non-par, but in fact that is not the case. So that is, going non-par is not the solution to penalty avoidance. So do you want me to pick up here?
Let's go ahead with the survey for which most have already responded.
Yes. So the question on the screen is, now that you know how MIPS will work, or at least you've been provided with this initial overview, and I know it was a lot of information, how do you intend to report next year? Are you going to just do a minimal amount of data to avoid the penalty, try to earn a small bonus, or go for the whole shebang and try to get a moderate bonus, do nothing and receive the penalty, or you don't know yet? And it's looking like the majority of responders are going to try to report for each MIPS category for 90 days to try to earn the bonus. And that's likely because, as we saw earlier, many of you participating in the webinar have been successful in the past, either doing IRIS Registry, EHR integration, IRIS Registry manual reporting, or claims. And so I think that's a great idea. If you've been successful in the past, I think you can be successful again next year.
Yeah, in fact, I think it should be a slam dunk for anybody who's been successful in the past.
Okay. So I think we can go to the next slide. There you go. Here's the questions we already answered. Okay, so as Sue mentioned, we've already received a lot of questions from our members about MIPS, and the Academy is in the process of developing tools and resources to help you succeed. But the IRIS Registry is one of the greatest resources that the Academy can provide to its members participating in MIPS. And participation, because of the IRIS Registry, we really think that ophthalmology is positioned better than a lot of other specialties participating in MIPS. So IRIS Registry participants will be able to meet the quality reporting requirements. They will be able to maximize their scores by earning bonus points for reporting on additional outcomes and high priority measures, and earn bonus points for electronic reporting of quality measures for those that have their EHRs integrated with the registry. In addition, participating in IRIS Registry will automatically earn you significant credit under the clinical practice improvement activity. So IRIS Registry is a great resource for Academy members under MIPS. In addition, the Academy has launched a new website, aao.org/Medicare, that has information about the new Medicare physician payment system, which we will continue to update as we develop additional resources. We also have set up an email address where members can ask questions about MIPS and have them answered by Academy experts. So if you have a question about MIPS or you have a specific question about how your practice should report, then you should email it to mips@aao.org.
So Rebecca,
also,
there
go ahead.
There are two questions that I see that actually we probably alluded to the answers, but we probably could briefly address. And one is, how does CMS know or define a group in MIPS reporting?
Okay, so under MIPS, kind of like as in PQRS, a group under CMS's definition is 2 or more providers participating under the same tax ID. So if you have 2 eligible clinicians participating and seeing patients under your tax ID, then you are considered a group and you have the option to report at the group level for MIPS if you would like to.
Right, and then another was the 90-day period that we're talking about is any 90 days. It doesn't key to a quarter or anything like that, does it?
No, it's not any specific 90 days. It's just any continuous 90-day period during the calendar year.
Right, and so that's really important for the CPIA activities. You basically choose your 90 days, and you can get that done.
Right.
And then there's a really hard question, which I think the answer is somewhat unfortunate, is suppose you don't have an EHR. What do you do?
So if you don't have an EHR, you do have plenty of options. You can use the IRIS Registry. While the measures groups are going away, which has been an option that non-EHR reporters have relied on for the past couple of years, you can still report individual quality measures. And earlier, Dr. Repka, you asked a question referencing the amount of time it would take to enter data. Well, just think, under PQRS, you are required to report over the full calendar year. Next year, MIPS, it's only 90 days. So reporting on 6 measures, which is less than 9 that's required today, should be doable for most of our members, even if you don't have an EHR, and you can do that by manually entering data into the IRIS Registry web portal, or you have the option to report by claims.
Right. However, for that questioner, the key on that is, of course, you get no credit in the ACI category without an EHR.
Right.
But for those who are reporting from claims or who are doing manual data entry, there are 48 measures. And of those 48 measures, again, at least one outcome or high priority. And there are 28 outcome and 10 high priority. So even without EHR, there are lots of options to report.
Did you have another question, Dr. Repka, that you wanted to raise?
I did not.
Okay. Well, the slide changed, but I also wanted to make a note that I recommend Academy members review the list of CodeQuest course locations. So the CodeQuest courses will provide some information on the MIPS program. So if you look on the Academy website, you can find and register for a course being offered near you. Okay, so Dr. Repka, now I'll turn it over to you to provide an overview of some of our advocacy efforts.
Thanks, Rebecca. Let me, in one other closing comment, and that's one of the problems we have as an organization is how to communicate this program to the members. And if there are ideas, in addition to questions about specifics of the programs, or what you need in effort to succeed in these programs, our team stands ready to create those items. And it's just sometimes we're trying to guess what the best way to work with a program that none of us has experienced yet. In terms of advocacy on this program, I just wanted to mention a couple things about what the Academy and Organized Medicine has done. This Pick Your Pace option that really saves the 2017 year is a big win. We also were able, compared with the proposed rule, to increase the low volume threshold, which had been $10,000 in allowed charges, up to $30,000. And that really does eliminate a number of our members. And lastly, the cost category, which we objected to, along with many, many others, about how difficult it is for CMS to actually do it, has been neutralized by setting to 0. So that those are true wins compared to the proposed rule that we saw in April. So in addition, CPIA was made easier. There are fewer activities to do. Again, most ophthalmic practices are 15 or fewer, so you get double points. You basically do 2 activities, and you max out that item, and it's only for 90 days. It was mentioned many times that the reporting period has been shortened from the full year to 90 days. And so that's really a very, I'll use a meaningful change in the ACI category, simply making it easier. Fewer requirements in the ACI category, and generally overall lower quality reporting burden in terms of the quality measures in that last bullet there. So the program was made easier. It's still a nuisance. It still is a lot of work to do. It still has a mission that hasn't been proven. Will it in fact make quality payment and value all come out together? I don't know. And I'm sure hope that some things are further improved, tweaked, or eliminated in the out years. So Sue, maybe in closing, it's your call.
This webinar is the largest webinar ever. We have just under 2,000 people registered. For those of you that were having difficulty with sound or other technical difficulties, the webinar, I've just been notified, will be posted on the Academy's website by next Wednesday, November 23rd. I'd like to thank everyone involved in the creation of this content, from those of you that submitted questions, for those of you that are spending this time, nearly an hour and a half with us, and certainly for all the speakers for their expertise, for their diving in deep to this topic to make it work. Remember, this is your academy, and our goal is to help you be successful. So please email communications@mips@aao.org. Tell us your unique situation, and let us help you find a solution.